In this talk, we're going to be looking at neoplastic changes, in particular to the skin associated with the foot. Now, for some of you, this may be something you're fully aware of. You may have seen a number of different types of lesions, some being malignant. It's very rare to find malignancy in the foot, probably less than 1%. So I've called this lumps and bumps, friend or foe, because for some of you, it's going to be a fear area, and you are always worried about what to say to patients. I call this neoplastic pathology, and therefore I'd like to try to encourage you to feel comfortable. Bear in mind, as a foot health practitioner or a podiatrist, you're more likely to see these lesions earlier than some other health professionals, largely because we're the ones that do see the foot in a reasonable amount of detail. The talk's going to be divided into three key areas. I want to emphasize working within your comfort zone. That's working within your knowledge. So foot health practitioners will certainly have a limited number of clinical hours during training compared to podiatrists who have three years under close supervision, as well as in the National Health Service. So they're at a greater advantage of seeing a lot more of these lesions. So that's the first thing. We need to work within our knowledge. It doesn't mean to say that you won't gain experience, but I think confidence from an early period of your investment into the professions will depend upon your background. For the majority, I'm going to be looking at the differentiation of lesions. I particularly want to look at the difference between normal and abnormal. But of course, we all know that a lot of lesions may look malignant, and that's really what this talk is about. This neoplastic pathology is emphasized around that. So we're going to look at a number of lesions that may look malignant but aren't malignant, but also may require a different approach. And then we've got the couching findings, which I'm going to talk about very briefly to start with, and I'll emphasize it towards the end of the lecture. The one thing that feet have in common for us is that we are one of the few professions that expose the foot and the skin, so we see it in detail compared to a number of health professionals. Because when people go on holiday, they find that they're exposed to sunshine. The ultraviolet rays are powerful. Many people go abroad where the sun is very bright, and as a result, skin damage can result. If not, in fact, you can get bites from various arthropods, and as a result, these lesions can arise and change, become infected, or you can get nasty problems associated with it. So we need to be aware a little bit of the history behind where people have been on their holidays. As we get older, of course, we have less capacity to reach our feet, and that just unfortunately comes with old age. Most people, in fact, are limited, and as a result, we are dependent upon the foot health professions to look after our feet. Now, I've mentioned about couching findings, and these are some words that are not recommended to be used during a consultation. It may well be that the patient brings it up, which is slightly different, but I wouldn't introduce into a conversation the terms malignant, tumour, cancer, or even abnormal. It is better to try to find a way around this, because the lesions which are malignant in the foot represent less than 1%. So it's terribly important that we tend to take a view that a lesion may need investigation because we're not sure. And it's not unreasonable to say that we don't have an expertise in the area of cancer, unless you happen to have access to tests, investigations and biopsies, which the average clinician won't have. That's kind of important. The next thing we need to do is to differentiate between the various malignancies, so we're familiar with the terms. If we look at melanoma, we've all heard of melanoma associated with skin, usually skin damage, and that tends to affect the skin alone. But it does metastasize, and I'll talk about that in just a moment. But the two main malignancies we need to be familiar with are carcinoma and sarcoma. Now, sarcoma is rather more common than carcinoma. Carcinomas tend to affect organs of the body, which includes the skin, and is represented by about 1% in the adult and 15% in children. With sarcomas, we actually see that these are far more common. About 80% affect the connective tissue, and this includes bone, cartilage, tendons, and ligaments. More so tendons, bone, and cartilage, I have to say. And there's also fibrosarcomas as well, we'll find affecting fibrous tissue. So it's all connected tissue to a greater extent. Now, in terms of what happens with these cancers, we introduce the term metastasis. You can have a primary or a secondary lesion, and when it comes to a primary lesion, it may well be in the organ, and it spreads via the lymphatics, and we can see here lymph goes to another tissue further away or through blood vessels, and the cancer cells then develop elsewhere, and they can develop in the foot, they can develop in the bone, and it's very, very hard to spot these. In fact, if we take a bone sarcoma, you may in fact not notice it there until someone breaks a metatarsal, and then it's picked up on X-ray. It can be that difficult to spot. When it comes to the foot, again, we can see metastasis back to organs, particularly with things like melanoma, and they can actually go to the brain as well. So we have to be mindful that these lesions can be quite deadly. Taking a clinical history is terribly important. We want to ensure that the information we gain can give us a hint as to the origins of the lesion, maybe. So asking them if they've been abroad is a good idea. Asking them if they've had a bite from an insect, which is not uncommon even in this country, or whether they've had any other form of injury, because injury to the skin can lead to changes in the skin, neoplastic changes, in other words. Neoplasm is just new growth, and it doesn't have to be malignant at all. The idea of taking a history gives you some origin of the problem. You want to know how long the lesion's been present for. You want to know what has made it worse, what has made it better necessarily. Have they had anything done about it? Has there been any treatment? The other thing that's important is to identify whether there's any pain. What level of pain? When does the pain hurt? Does it arise at night? These are all key areas that do give you a better understanding of the potential prognosis. Once you've got a clear history and you write all that down, then you want to move on to clinical examination. Clinical examination will involve not only looking, but also feeling the patient's lesion, if at all possible, except for naturally when it's infected, but then we'd be wearing gloves as well, sterile gloves. As far as the observation is concerned, we can use the ABCDEs that we apply to melanoma, which I'm sure you're familiar with, but I'll quickly go over those just to refresh your mind. So we start with asymmetry. Asymmetry is to do with the shape, essentially. Now, I'm not suggesting all lesions are always symmetrical, but it does give you an idea if the symmetry is fairly even all around. So symmetry is one thing, and we'll look at some examples. Border gives you an idea if it's capsulate, so it's got like a wall around the castle, if you like. This may be well defined, or it might be slightly less discrete, but malignancy has a tendency to lose its border, and it's a bit more ragged. The next thing we need to check is the colour. Colour change is really important, because if colour changes from, unless it clears up entirely and goes back to pink, but if it changes colour from maybe a black to a brown, brown to a red, then that may be a reason for concern. Measuring the lesion is really valuable. If the patient has got a way of doing that and keeps an eye on it, that's really good. If they can bring a picture in even of the lesion on their mobile phone. So some kind of measurement, plotting the history of the lesion enlarging is really helpful. And lastly, we talk about evolving. Evolving means, is there going to be a significant change? So we might see bleeding, there might be infection, and there might be suddenly a surge of pain. So that's evolving. Now, generally speaking, the foot shouldn't be that swollen, but we must bear in mind that people do present with pitting edema. And you can see the pitting edema where the clinicians pressed the tissues, and this is where the lymphatics and the venous return are poor, or shall we say inefficient. So it might be a valve problem in the legs, or it could even be the pump itself. The heart has heart failure, and as a consequence, the gravity doesn't allow the fluid to be returned as efficiently as it would be. If we compare this type of swelling, which is known as edema, to this type of swelling, we can see that the area around here is swollen. It's very soft. It doesn't have any organisation to it. This is actually a lipoma, and lipomas are fat. And this is harmless, and it doesn't need anything doing to it particularly. It doesn't get in the way. It's not painful. But I point out that the anatomy of the foot and the intermetatarsal spaces provides a vast area where lesions can be hidden. It's a bit like an army hiding between valleys of two hills. So we do need to have an idea of how extensive some of these lesions are. In this particular case, the patient was reassured after imaging to reassure the clinician as much as anything. The word oma is actually just means swelling as well, and or tumour. So we actually find the word follows the suffix in many cases. Let's have a look at an overview of some of the conditions we might be considering. In many cases, you'll actually see here the word oma here, oma. These all have omas. Angio means blood. This tends to be around the muscle of the endothelial lining of the artery. We see eccrine here as associated with sweat glands, and this is blood clot, and this is associated with nerves. So really, when it comes to making up words, you can break this down into its tissue form. On this side, these are some of the conditions I'll be dealing with, and we'll just follow through with all of those in a moment. I've really preferred to look at key areas, so I'm going to look at granulation as one condition, infection closely related. Bone and cartilage are going to be associated obviously with hard tissue, and we've got fibrous types of tissue. Melanoma and epithelioma are malignancies, and we'll deal with those at the ends to differentiate. So to start with, we can look at a normal nail, and we can look at a normal anatomy. This is the nail matrix around here, and the matrix largely is here. It's also underneath the nail plate, and there's some association with the hypernychium, which is tightly bound with a fibrous band. The area here, the sulci, also have nail cells, particularly around here, and so damage to that can cause problems. The nail plate is nice and healthy. It's not thickened. It's got a nice edge to it here. There's a little bit of callus just here. Okay, suggests a mild onychophosis, but in fact you wouldn't want to do anything with that unless it was symptomatic. This is known as the sole horn, or nail sole horn, and this is the lunula here. You can see that just there, and this is the eponychium. The area here suggests trauma, and the reason it's trauma because this is caused by a direct blow, a blunt object, or stabbing in the shoe, and the nail has lifted and there's blood underneath it. And the problem with this is it's extremely painful unless you can actually release the blood from it by drilling through the nail plate and releasing the blood. And you've really got to do this fairly quickly for it to be effective. So that's a subungual hematoma. Now we're going to move on to the infection, or the infectious type. The picture on the left-hand side is a typical hypergranulation here, and we can see granulomatous formation here. The nail is discarded possibly due to antiseptic, but it can change, and you've got an area of poor healing here. If we look at the nail plate, this has almost certainly been cut down, and it might have an edge here to it, and on this side it's been cut at an angle here to try and relieve things. So you can see that the patient's probably had a good go at that and got themselves into a wee bit of problem. On the picture here, this is also an ingrown toenail, often known as onychocryptosis. The granulomas here are enlarged, they cover the whole of the nail plate. It's very purulent, it will have a nasty smell to it because the bacteria will have been thriving on the sweat, which is increased. And this appearance here, which is, well, it's not quite corrugated, but it's very uneven and indented, is due to abscesses, chronic abscess formation. So this hasn't just happened overnight. This is something that's either been left or, in fact, has had a repeat number of infections and, as a consequence, needs greater attention. Whereas our podiatrists will manage this simple nail very, very easily. On this side, there may be a requirement for removing as much tissue as this on both sides here, as well as bone, in order to restore the shape of the toe. But this is actually due to infection, abscesses, and it's a chronic, long-standing ingrown toenail. So it's not malignant. But, and here is the but, if infections can actually linger for long enough, they can in fact change and become malignant. And it's always worthwhile bearing that in mind. And that's why we need to really treat these things. Okay, so we've got two very similar appearances here. Notice the derm net here at the top. I use a number of slides from this wonderful internet source. It's a New Zealand dermatology source, free to access. There is a professional form, but there is a bit of a long waiting list to get onto that. But it gives you plenty of information and accessible at fingertips. The one on the left is a subungual hematoma. Although this is actually slightly asymmetrical in shape, it still has a symmetry within the nail plate. Whereas on this side, you can actually see the splinters off here. And this obviously is very uneven here, which is suggestive of a subungual melanoma. A biopsy needs to be performed, but the problem with this is if it's left long enough, it can metastasize, and the patients, in fact, are put at risk because melanomas do kill. There's no question about it. And we've lost patients, and we've even lost colleagues from melanoma, particularly the skin. I need to talk about normal as much as abnormal. And in this case, you can see that this is an uneven nail. It's thickened, it's striated, it's discoloured, it's a browny yellow appearance. And you can actually compare the other nails, and these are all pretty similar, and they've got nail fungal infection. The condition's known as onychomycosis, and the importance is that we actually compare both feet, and we can see there's a certain symmetry in the infection. So we're not necessarily worried, and we can manage this reasonably well in clinic, reducing the nail, making sure that we get rid of infection and can treat the nail bed locally. And this is something podiatrists are very good at doing as well, and can assist. It is better to treat feet locally rather than putting them on some of the medications like terbinafine, because this does need monitoring for bloods, because it can affect the liver. So local treatment really works quite well if you're prepared, or the patient's prepared, to go through a planned treatment. Now, cosmetic approaches to nails might be one thing that the patient considers, but as patients get older, clearly they can't reach their feet and need assistance for even the basic things. Cutting back nails to expose underlying lesions like this is important. This is a subungual granuloma. It could be an ulcer, and we've seen chronic ulcers lie underneath nails which have not been treated properly. And if this is the case, then they can become infected, and long-standing infection in immunocompromised patients can lead to bone infection, which is known as osteomyelitis. So we need to bear that in mind. This lesion here is a glomus tumour, unusual, very painful, and it's associated with the local arterial blood vessels, where cells clump around the vessels, stopping it expanding, particularly when the environment heats up. So it needs to lose heat by expanding, and it'll contract when it's cold. So when it expands, it becomes very painful. This needs to be excised. We come to a couple of conditions here, and again I'd like to show you more normal. This is a normal post-operative nail ablation. You can see the edge of the nail here growing forwards. The nail grows at approximately 0.1 millimeters a day. This is just the effects of the whatever's being carried out, the ablation or even phenolization possibly. If it's been phenolized, this may very well come back as a nice clean nail bed, but it possibly may be a thinner nail plate, which may in fact consequently be quite useful to the patient if it's no longer thick. So we move on to this condition known as pterygium. And pterygium is associated with a number of skin conditions, which includes lichen planus. It can involve psoriasis, rheumatoid arthritis, vasculitis, sclerosis, which is known as tuberous sclerosis. And I'm going to say something a bit about that in a moment. You can see the eponychium is affected, which causes changes in the nail plate. If the eponychium is affected, it affects the underlying matrix. The nail plate's delaminated, and you might remember from your anatomy, it essentially forms from 3 layers. The nail bed, the sides of the toe, as well as the eponychium, and so this becomes delaminated. This is a condition that just needs gentle managing, but otherwise it's harmless on its own. Now this little chap I call the little mole coming out of the furrow. It is known as periungual fibroma. So this tissue is fibrous, fibroblastic if you like, and it's totally benign. And you can see many patients with this condition and they have no associated other conditions. But as I mentioned in the pterygium, it can be associated with tuberous sclerosis. And tuberous sclerosis is where parts of the body have these clumps of cells which form. It can form in the skin, it can form in the brain, may be associated with seizures and even dementia. So good history will actually elucidate that, but as they appear, they are harmless, they may bleed, and they certainly can get in the way. And if you can see the edge of the nail, it actually curves round like that, so it causes a kind of a furrow. We would normally make an incision back here, open that up, and you'll actually track the lesion way back here, so it lies underneath, and that can be removed and sutured together, and the nail may grow back, it may not grow back. We usually advise the patients to expect it not to, and a partial nail ablation can be carried out if it's a cosmetic issue. So that's periungual fibroma, not uncommon in feet. You'll see them in different sizes. Some can get very, very large indeed, and others are just literally look like potato tubers. This is perhaps the most fun condition to deal with. It's associated with a subungual exostosis. The nail is deformed, you can see here quite clearly, and it forms this well demarcated area around here, and the keratin here gets thickened because of pressure and changes. It's a bit of a debilitating condition, particularly when it gets large like this. If we have a look at the x-ray here, you can see from the medial oblique view that's where the foot's rotated at 45 degrees and the view's taken, because taking it straight on doesn't show much. You can actually see the projection here quite clearly. And if we look to the toe on this side, you can actually see this is expanded here. It's expansile. The cortex continues, and you can see this picture here where it's expanded. It looks very bulbous. I have to say that this is very interesting because we see a number of them, and the condition that you can also find associated with is with an osteochondroma, and that simply means bone and cartilage. So the swelling of cartilage on top of the bone. So you get a cartilage cap. This tends to affect individuals really up to the mid-30s. I'm not saying you can't get it later, but it tends to be a younger person's condition. My pathologist always sent off all my samples to a second lab. I think this was just a question of audit more than anything else, but certainly this was kept practiced at my hospital, so we always got a second opinion, which always came back. The pathologist was always accurate from my hospital anyway, so it was reassuring. So I thought it was an osteochondroma here, and then when you see the report come back that it confirms it, it's always encouraging. During 1993 to 2002, I undertook a catalogue of some 500 pathologies to give me a wide idea of different lesions and what actually happened, because I was quite interested in some of the descriptions and the types of cells which were involved. Moving on to the last of these nasty nail problems, this is known as a carcinoma. It's a squamous cell carcinoma, and these can go quite deep. Now, this area here is a finger, and it looks quite horrible from the point of view. It looks as though it's an open wound. I had a case, a 70-year-old who came in, and she said to me, Mr. Tollafield, I can't cut my toenail. And I said, well, you haven't got a nail there. And this is what it kind of looked like. If I sort of describe it, it came like this, and then the toes round like that. So this had this uneven, shiny appearance here. We did a punch biopsy. I did a punch biopsy, should I say. Took a piece out there like that, sent that off to the pathologist. It goes right down to bone, by the way, to make sure we've got all the tissue. And that came back as a squamous cell carcinoma. Now, these are slightly rare. About 2 in 10 occur compared to the more superficial basal cell carcinoma, which is about 8 out of 10 incidences. These are invasive if left. They're contained up to a point. They don't tend to metastasize in the same way as other lesions do. But in this particular case, she had to have an amputation. This is the tissue that was removed here. All of this came out here, including the bone. You see the bone's disappeared. And then we flap this back from here to here, rejoin it back up as we did there. And she's got some fat that allows her to walk on it. So that's quite helpful. On my website, which I'll give you details towards the end, you'll see that there's an article on biopsies. It's quite a simple, basic article just to give you some ideas of the types of excisions or biopsies that are performed. This is a punch biopsy, and you can see as I go to the next slide, this area here is then taken out as a conical sample, then sent off to the lab. So that kind of completes the nail surgery. So we now need to move on to soft tissue.